Hello, my friends. This is Dr. Jeffrey Beto, and I'm broadcasting to you from Philadelphia, Pennsylvania. This is the screencast recording of a recent article that I published called The Best Knee Injections. This article is published on my website, chronicpainreliefoptions.com, which is a website that is designed for people with chronic pain, giving them options for treatment, in many cases explaining the mechanism of their pain. Now, if you're at all familiar with my website, you know that all of my monographs also tell people that they need to have an accurate history and physical done in order to get the proper diagnosis for their chronic pain condition, and in order to know what the mechanism of the pain is. Crucial to being able to put together a strategy to get relief of chronic pain is an understanding of what the mechanism of the pain is, the exact physiologic mechanism. So here we are. This is a screenshot from my website, Chronic Pain Relief Options, and here's the monograph title, The Best Knee Injections. And I always start my monographs with have you considered? And it's important for you to understand just basically that the knee is the most commonly injured joint in people who are physically active. It is a joint that is under stress. It has a number of disadvantage structurally from other joints. And if you haven't watched a sporting event and seen a knee injury, you probably, it's not a very vigorous activity. It seems that when I watch football games, at least one or two of the players get their knees injured during a sporting event. And what I'm going to teach you in this monograph is really a distillation of many, many years of the practice of pain management. And from listening to patients, reading the medical literature, and just watching the response of different techniques and different mixes of medicines injected, this is what I think is the most optimal way to inject a knee. So even if you're a medical practitioner, I think you're going to learn some new things regarding what I'm talking about here. Before we go any further, though, I think it's important for us to begin to talk a little bit about the anatomy and physiology of the knee. Of course, in the monograph, I go through it in much more detail, but as I've already said, the knee is a mechanically at-risk joint. And you can think of the knee as two poles lashed together with cords. If you've ever tried to build a tent and put two poles together, no matter how tightly you wrap the cords around the ends of those two poles, it's almost impossible to keep them from moving. And so it is with the knee. The knee is moving in multiple different planes when it moves, although the major motion is a swinging hinge type of motion. The knee also has two curious interior structures called menisci, and this is where they're located right here. You can see them on the diagram. These structures help to cushion and stabilize the knee, because right here, where I'm pointing, and under the menisci here and here, is this very slippery surface called synovial cartilage. If these menisci were not there to guide these two surfaces that are sliding one upon the other, the knee would slide all over the place. It would be almost impossible to keep the femur and the tibia in close association with each other. And even at bed rest, the knee is difficult to immobilize. If you ask friends who have had knee surgery, I remember when my son had his ACL replaced, that even just small motions of rolling back and forth causes the knee to move. And bracing the knee, you see these expensive braces that are sold, bracing the knee even gives it little support. The professional football players wear these braces, and really what the studies have shown is that the braces teach the player to change the way they use that particular knee that's dysfunctional, and it doesn't in and of itself give a great deal of support. Now, as I said previously, the knee is a swinging hinge type mechanism, And in the standing position, the knee ligaments are relatively loose because the knee is compressed. So I think the position that is of greatest risk in someone with a knee injury is when the patella is and the knee is partly bent, and not in a full bend position, but maybe 10 or 20 degrees. That's a very risky position for the knee, and it's easily injured in that position. And you can see here in the monograph, the 5 or 10 degree bend position places the knee in a great deal of risk, because there's enough play in the ligaments at that point that a hit from the side or the back could really tear the ligaments easily. So ligamental shearing is a major mechanism of injury in sports, and of course there's a number of ways that is repaired these days, and quite well, I might add, with what are called autograft, where a tendon is taken from elsewhere in your body and it's placed into the knee surgically, or what are called allograft transplants, which is a cadaver ligament which has been treated so that it doesn't get immunologically rejected, is placed in the ACL or PCL position. Now, there are a number of conditions that respond to knee injection therapies. This is a listing. It's not a complete listing. The most common, of course, is degenerative joint disease of the knee, and this is where the cartilage gets pitted and worn out, and then in some cases you actually get bone-on-bone rubbing, which is extremely painful. There's also a condition where the cartilage wears away in the bottom of the kneecap called patellar chondromalacia. And then, of course, the usual rheumatoid arthritis and other autoimmune conditions. There's certain select tendon and ligamentous injuries that will be helped. And then, of course, there's cystic conditions of the cartilage, and tumorous growths of the knee may be helped also. But it's important to note that knee injections do not significantly alter the ongoing deterioration of the knee from a chronic condition. They're mostly for symptomatic relief. So don't think that, well, if you get a knee injection and the pain is significantly relieved, that it's never going to come back. It's often reflective of an ongoing process that's going on unbeknownst to the patient. There are a number of different medications that can be injected into the knee. Generally speaking, the medications will be a mix of a local anesthetic agent, an injectable corticosteroid, and of course the skin usually needs to be prepped because you don't want there to be an unusual amount of bacteria on the skin when you pierce it with a needle. And for patients' comfort's sake, some doctors like to use a skin anesthetic agent, a refrigerant in particular, that they spray on the skin. The medications I used were as follows. The first thing I used was Marcaine. Marcaine is a local anesthetic agent that is used for injections of different types, epidurals and skin injections, and is not generally used for joint injections because there is a history in the medical literature that it can cause cartilage damage. Now, when you look and examine the studies where this happened, it was in cases where the orthopedic surgeon had used a 0.5% concentration, and it was a continuous infusion into the joint, trying to diminish, for instance, after a knee surgery, and then there was a continuous infusion of fluid. Those people had a very high complication rate for cartilage damage, and once the cartilage damage occurred, it would not stop. It was not curable. Now, in our mix, we used a different dose completely, and I'll explain that to you in just a moment. In the mix that I made for my patients, I would mix 1 cc of a 0.25% Marcaine. That's 50% less in the concentration from the other Marcaine that was the study showed to be more damaging. Of course, this is not an infusion of Marcaine into the joint space. It's a one-time injection. And I would mix it with 40 milligrams of Depomedrol, or 1 cc. And the combination of that mix never resulted in any difficulties whatsoever. Now, Depomedrol is a moderate-acting corticosteroid that is a suspension. And although there can be lots of side effects from steroids given systemically, when they're injected into a joint, the amount of systemic absorption is minimal, and so the side effects is minimal. Remember that this is a substance that's an anti-inflammatory, and it calms down the swelling. So our mix was 1 cc of Depomedrol mixed with 1 cc of 0.25% Marcaine. And then I also mixed that with another substance called Serapin, which I'm going to talk to you about next. So in with our mix of the 0.25% Marcaine, 1 cc, and the 1 cc or 40 milligrams of Depomedrol, I would mix in another cc of another substance called Serapin. And Serapin is a natural anti-inflammatory made from the pitcher plant. I did that because using Serapin in this way amplifies the effect of the Depomedrol. I can keep my dose of Depomedrol relatively low, and it also prolongs the effect of the Depomedrol. This comes in a multi-dose vial, just as the other two do. And I found this to be incredibly helpful. And so this categorical statement that I made here on my monograph is that the injectable mix that I used with over 26 years of experience was 1 cc of Marcaine, 0.25%, with 1 cc of Depomedrol, of 40 milligrams per cc, and 1 cc of Serapin for a total volume of 3 cc's. Okay, and this combination resulted in every single patient that I ever injected getting significant relief. The anesthetic agent, the Marcaine, would give relief and lasting relief for up to maybe 8 or 10 hours. By that time, the Depomedrol and the Serapin were beginning to work, and the patients had prolonged relief. I cannot recall any patient not obtaining relief nor having any serious side effects after almost 3 decades of giving injections with this solution. I don't know of any other physicians who use this particular combination. I'm sure there's some somewhere. But in my community in Philadelphia, I do not believe there was anybody who was using Marcaine, Depomedrol, and Serapin as the mix for their joint injections for the knee.